Hello, this is Jessica Assefa and welcoming you to May's episode of Rising Stars. Today, we're going to be interviewing two guests, Kori Haddix, who's one of Press Ganey's own. She works on the Hyperlift team, managing data and working as a consultant, helping folks math path their way to 5 stars and keeping them there. And we also have Genia Fick, who's the Chief Quality Officer for Inland Empire Health Plan. Genia has done a ton of work with both the Medicaid and Medicare populations. She has experience with some of our new star measures, working with a Medicaid population. And we'll talk a little bit about what she's doing there to move those measures and how she can transition and tailor some of those strategies for the Medicare population. Our topic today is display measures. So we're going to start out talking about display measures generally, how we can get ahead of monitoring, tracking performance in those measures, and then thought we would do a deep dive into the new star measure, depression screening and follow-up, DSF, which is a new measure that we recently learned will be coming to star year 2029 based on next year's performance. So without further ado, I'll pass the mic to Kori. How about you introduce yourself? Tell us a little bit more about you, your background, some of the work you've done looking into this measure specifically, and then we'll pass over to Genia to do the same.
Sure. Thanks, Jessica. Happy to be on today. I come from a background in healthcare quality, about 20 years of experience, half on the provider side and half in health plans. So coming in with a lot of experience on these kinds of clinical measures, and excited to be working on this one, helping our clients at Press Ganey really get a jump on star ratings for measurement year 27, knowing how to prepare themselves with these display measures in order to be successful going forward and kind of get a jump on the competition there. Genia?
Well, it's nice to meet everyone, and I have been with Inland Empire Health Plan for over 20 years, and we've been in the Medicaid and Medicare space for over a decade. And so, really looking forward to spending some time talking about a measure that has been pretty present in our Medicaid measure set for some time, and look forward to just having this fun chat.
I am too. So super exciting. We've talked about so many other star measures, and I've not heard of a podcast focused on DSF yet. So I hope we're the first out there, and I hope we have some exciting and new and helpful information for all of you, so you can enter star year 2029 strong. In that space, Kori, how about if you ground us? It would be great just for folks that don't know maybe or haven't had opportunity to look in, what is this measure? What's it measuring? And then maybe jump into what are you seeing nationally and performance-wise for some of our display measures.
Yeah, this measure actually has two components. So there's a screening component, which looks at screening your entire population for depression. And then there's a follow-up component that looks at, of those who screened positive, how many had a follow-up within a 30-day period. CMS is actually going to use an average between those two components. So the two submeasures will be averaged together to produce the rate that will be used in the measurement 27 stars 29 rating system. I did do a little bit of work on just identifying how this measure performs and seeing where the greatest opportunity might be. Let me just show you guys what I saw in a very quick, very quick analysis. Let me pull this up. I thought it was pretty interesting to see looking at the screening submeasure to see the average. This is the low end of the range, the high end of the range, and the average here is 23%. This is just for the first year of display. And then for the follow-up measure, the average is more like 81% with the range between 36 and 100%. So it was really interesting to see the variation in performance between these two submeasures. At first glance, it really looks like screening is the key opportunity, right? That if we can really focus on this lower rate, that's our opportunity to bring things up, whereas the average on the follow-up measure is much higher. But when I started looking at the performance between high and low performing plans, those higher performing plans actually didn't have any level of consistency between which of these submeasures they did better on. Some of them were very high on a follow-up measure and fairly low on screening, and some of them were the opposite. So it was really interesting. I think each plan is going to have to take a look at their own display data to see where their opportunity lies. And then speaking with a few of our clients, I've heard a lot of really good insights into into understanding what is driving some of that. A lot of it is data. And so I'd love for
Hmm.
Genia to jump in and talk a little bit about what she's seen on her end.
Yeah, thanks, Corey, for sharing that kind of national view of the performance so far. I think, this measure is just entirely different. It's a clinical data based measure, right? So there's no longer the ability for plans to use claims information at all, which is so different than any of the other HEDIS measures we've had in the past. And so I think, primarily it starts with where are we going to find this information for our members across your network. And so thinking about the providers as a primary source, looking at our primary care network as our starting out point for depression screenings, but also recognizing that there's opportunity with our care management teams also who may be doing depression screenings in their normal workflows. And so I think as far as, where do we begin? It's really starting off with just doing an inventory of where might that data live in your organization. Depending on the way your provider network is structured, we really needed to look at where's the largest sort of data sources available to us to start tapping into it and starting to kind of build the mechanisms to measure and capture those LOINC codes that reflect the depression screening. And so, I think there's finding the data first, but then there's also the defining of the workflows for that follow-up care, and making sure you understand where that information might live in the EHR of your provider or where that information may live in your care management system. So a lot of data mapping really is kind of the first step for getting these measures kind of set in motion.
I hear Genia with some clients talking about challenges, as if getting data and data sharing and related potential privacy issues sometimes or the perceiving on the providers and that there could be can be challenging. That's almost tenfold when it comes to behavioral health providers and helping them to see you as part of the care team and explaining it's okay to share that data. Are you running into any additional hoops you have to jump through or barriers due to the fact that it is behavioral health?
We are experiencing some primary care provider practices sort of putting, or I guess, filtering out that information so it wouldn't flow to the plan if it's considered a
Mm.
behavioral health sort of data element. And so we are experiencing that in some cases, fortunately not across the board. We have been working on this measure in our Medicaid line of business for over 5 years now, and so I think we've done a lot of education with primary care practices about this is part of the standard screenings that we expect our primary care network to do, that these are measures that we're now being held accountable to perform better in, and so that I think we that helps to smooth some of those barriers out when we start getting into the data sharing conversations. But we are not tapping into our behavioral health network of providers for the
Okay.
depression screenings as a starting out point. We really have been focusing on primary care practice depression screenings and the follow-up plan from the primary care practice along with care managers. So I do imagine if an organization is going to try to work through their behavioral health network, that there would have to be conversations about disclosures and what's okay to share.
That's really helpful. How about you, Corey? I know you talk with so many clients across the nation on the daily, and I'm sure this topic comes up more than once. What are we doing with this measure? What are you hearing as far as barriers folks are bumping up into when trying to perform well in this measure? Those that are ahead of the game, right, and already working it, and what's working well? What's the
Yeah,
word on the street?
first off, there's a lot of variation in how people manage display measures in the first place. And I'm sure you've seen this too, Jessica, in the plans that you've worked with over the course of your consulting work. I, I'm always fascinated to see that, some plans don't even think about measures until they come into the ratings. They're not even considering them while they're on display. A lot of my clients right now are working towards a process to enable them to do more of that. So they're not currently really doing any kind of strategy around it, but they really want to build that out. And so trying to help them think about the best way to do that, what you can learn from measures while they're on display is super valuable, including both on your own data, right? How you're performing, but then also how the industry is performing and understanding where you have room for improvement. Because sometimes you look at your data and you're like, well, that seems okay. And then you
Right.
see what the cut points are and you decide, maybe it's not okay after all. So that's been really interesting. I think what I see high performing plans do is really use the display period as a time of learning. So they're looking at how they're doing and then how the industry is doing that comparison point. And then they're also starting to test intervention. So you do need to be able to get a little bit of a budget, right? You can use PDSA cycles to really minimize the amount of money you need to spend on an intervention, but start to find out where those challenge points are. Genia had some really great points about the data piece. That doesn't really cost you anything. It's just the work of getting the data flowing. But understanding the key points in this measure, things like you need to be able to identify that the screening was done with a validated instrument. How do you do that? It's through a link code, and those don't come in, right? Like Genia was saying, that just isn't normal. So you have to figure out how to do that, or you've got to work with your HEDIS team on how to map it. On the follow-up piece, how are you connecting all those different pieces? It could come from another PCP visit. It could come from a specialist behavioral health visit. It could come from a medication claim. So, just understanding all those different pieces and how those pieces flow or don't into your own data where you're missing the boat. So I think there's a lot of conversations to be had with primary care at this point. I think, well, there's been a lot of talk about this being a behavioral health measure, one of the first behavioral health measures in STARS, if you don't count HOS, right? I think really this is going to happen in primary care. I don't think, like Genia was saying, I don't think there's going to need to be a ton of work to delve into that behavioral health network necessarily. That's probably not where you're missing the data and the information that you need for this one.
That's so helpful directionally. You know, Genia, you've got the benefit of, I'm sure your Medicaid product line is in some way, shape, or form a feeder for your Medicare, right? So are you doing anything differently with folks as they approach age 65 and they become eligible for Medicare? Just in that while they're still Medicaid and in that window about to enter Medicare, is there anything you're doing differently or a little more intensely for those populations about to enter the measure for STARS?
Yeah, that's a great question. I think at this stage, we are not kind of isolating that transition group specifically, but we have been looking at some of our standard, Medicare workflows and exploring and introducing the depression screening into those workflows, right? So we know we all have to do the health risk assessment for all of our members. And so that's a great opportunity to build in the PHQ2, potentially to get that initial screening done right away. And so I think there's just looking at where can you fit into existing processes, some of those workflows that supports the measure. With the HRAs, often the plans are doing those, or care management. Resources are doing those. And so it's a little bit easier to access that data sometimes than it is to go into the primary care practice for that data. So it's also being strategic about where might you find the easiest you know process to bolt
Right.
on to for this new measure.
That's helpful. How about either of you, Kori or Ginny, as Ginny, as you do the work yourself and with your teams, and Kori, as you work along with those leaders across the country that are doing the work, have you heard of anyone starting to segment members for this measure, like looking at performance for duals versus non-duals, high risk populations, looking maybe focusing on where outcomes might differ between different groups, and you can't have a one size fits all strategy?
Yeah, I mean, I'll start. I think that we definitely see differences in populations. I think the more engaged into care that a patient's, the higher likelihood we are to get that screening done for them. And so I think, in the Medicare population, they tend to be much more engaged, seeing providers, regularly throughout the year. You've got the care teams doing this work. We're a D-SNP plan, so if virtually every member has a care manager assigned. And so there's a lot of active engagement. So we interestingly see a higher depression screening rate in our Medicare population compared to our Medi-Cal or Medicaid population, even though we've been working on the Medicaid
Oh,
measure for a long time. So it's interesting that even though we've been doing this only in the display period so far, we're already seeing higher performance in the Medicare population. So, yeah, I think
that
engagement in care is an important, I think, trigger to help, get success in the measure.
you would just think the opposite, right? I mean, the way you explain it, it makes sense and leads to that conclusion. But sitting on the outside, you'd think it would be the duals that would tend to struggle a little more than the non-duals with this measure. But that would be an
Right.
interesting study to do more broadly, Corey, right? Just to look
Yeah.
in not just the CMS designated SNP, but look for those plans that are actually they don't have a 10% SNP PBP, but they're 90% SNP enrollment and see how they perform.
I think this is such a great opportunity to draw in some of those social risk factors
Yeah.
and utilize those for some of that segmentation. So CMS segments the measure by age. And of course, you can also look, at your own data by geography and all those other factors, right? But I think some of those social risk factors could be really interesting to start to
Yeah.
identify which of those are having an impact on either aspect of the screening or the follow-up and driving some of the behavioral changes that you might see between those different populations. So that would be a great place to start. Even though EHO for All has gone away, it's still really valuable information to
100%.
use for all of our measures to identify where those barriers come into play.
Yeah, that's so true. That's so true. I know I always forget about the 2 components, these sneaky measures like TRC where it's almost like
Right.
2 to 4 measures rolled into 1 and
Right.
still single weighted, right? Twice the work for half
Yes.
the points.
That's why you got to get a head start, right?
Yeah, for I know one thing we were all chatting about before too, before we started recording was just the importance of not working measures in a silo, right? Not saying, okay, this is my approach for, the depression screening and follow-up measure, and this is my approach for the HOS behavioral health measure, and this is my cat, et cetera, right? And um, Corey, I think you really kind of dove into that in our conversation. I know you've done some work looking at that in the past, just the correlation between this new measure and some of those measures that have more longevity in stars, which I would love to throw the mic back your way to talk about that a little bit. And then maybe the three of us can brainstorm how do we turn that into strategy? What does that look like where we're really comprehensively working multiple measures at once
Yeah.
because those multiple measures are often one individual, right? Not three.
Yes, absolutely. And
Mhm.
speaking of multipliers in terms of, multiple measures within a single average measure, I think this measure is also going to be a multiplier. So one thing that was kind of circulating in my head as I was reading the final rule, and then I was also reading Press Ganey's State of Member Experience report that came out. The State of Member Experience report had a whole section on how behavioral health is really going to be a multiplier in member experience. And so I think that's key for me in thinking back to how all of these measures are going to connect with each other. So I'm thinking about the health outcome survey measures that we mentioned earlier, improving or maintaining mental health, of course, right?
Mhm.
But then that measure is so closely correlated with improving or maintaining physical health. And some of the questions actually overlap between those two measures. And those are both triple weighted measures. There aren't that many weighted measures left this year. They'll come back next year. But we've got to really hit those ones hard. CAPS would be the other piece of that. So thinking about that connection between behavioral health and member experience, it really is getting appointments and care quickly, getting needed care, the rating of the health plan, rating of healthcare quality. I mean, lots of different CAPS measures that are all double weighted, right? So this may be one single weighted measure coming in next year, but it's going to have a connection and correlation with all of these other higher weighted measures. And this is the time to learn how those things work and really get that head start, get that competitive advantage for your plan.
I
I
think
love
so.
that, Corey. I think another important piece, care coordination and the importance of getting the member, supporting the member to that next place, of service that they need. And so thinking of that connection as well, if a provider is doing the depression screening and facilitating the connection to the behavioral health resource that the member needs, I think that has a nice natural connection to support that
Definitely.
care coordination measure for member experience. So yeah, I totally agree with you. There's a lot of great synergy around many of these measures, and so thinking about it more holistically, I think is definitely the way to go. And then, when you think about the clinical data sets, right? I mean, there's more and more of these coming. And so I think just having this is one specific measure where we are heavily dependent on clinical data sources, but there's more, right, in the STARS program today. And I think the more we do at the plan to get better at those data connections for clinical data measures, that'll help us be more successful more holistically as well. So I love that concept, Kori, of that synergy
Yeah.
and looking for where these measures intersect.
I was even thinking from a health plan's perspective, probably some of what you're going to do to drive that screening rate at least is encourage an annual wellness visit, right? Now, what
Absolutely.
else happens in an annual wellness visit?
A lot of
That's
things.
where you get all your preventive screenings ordered. That's where you get all of your chronic conditions documented, both from a risk adjustment perspective and for quality, right? So you've got all these things coming through that are impacting your health plan from a quality angle and from a financial angle. So it's going to be really important, I think.
Yeah, for sure. For sure. You know what else might be fun to look at? I don't mean to keep calling up your slides. I know they were like this, but I love the slide where you were just looking at behavior of display measures generally, right? And kind of what colors look like, the distance between them while they're on display versus when they come into the ratings. Do you have, not to put you on the spot, but do you have it handy to?
Do. Yeah, I did think this was interesting. So I went back to the FMC measure, which was one of the more recent ones to come in, but had enough history both on the display side and the rating side to just kind of see how this looked. I compared it with a couple of other measures that are more recent that I could only see the display history and pretty well aligned. I think it goes back to what we were talking about earlier of this is your opportunity to build that competitive advantage by understanding your performance and industry performance before everybody else starts working on it. So one caveat, this year is 2020 STARS year, which means Measure Mirror 20, Measure Mirror 2020, so display of 2022. That's COVID. So you'll see some weirdness in the trends. That's because of COVID. But so I just graphed out essentially the low end of the range, the high end of the range in this darker blue, and then the difference between them in this light pink, and then this dark pink is the average. So just to show you the 4 years on display, this is the line where it moved into the star ratings in the next 3 years. And you can see for the most part, there's with the ignoring this COVID piece, there's not a lot of change in the behavior of either the range or the average across those 4 years on display. Nobody's really doing much to drive improvement on that measure. Even that first year, very little change. The greatest change actually was the decrease in the low end of the range, which was interesting. Um, but then it's really year 2 and year 3 where everybody starts putting interventions in place and resource allocation, all those sorts of things to start to drive improvement up. The other thing I found really interesting here is there's not even that much change in the high end of the range. The biggest change is in the low end of the range coming up, right? So when you see this range drop down, the variation between the high and the low, the majority of that is coming because the low end is coming up. So that's where I'm talking about, display year 1, that's your chance to look at your own performance, see what your competitors are doing, how you're comparing against them, and where you have opportunity to improve. In this case, there's 2 sub-measures, so look at them both. Look at all those different variations and stratifications that we talked about within them. And then year 2 is a time to really start putting some things into place to test things out. What works in this population? Where are you missing? Where do you have opportunity? Start to dig in there. If you wait until star ratings come out in the first year and cut points come out in the first year, you're going to be with everybody else. So you're not necessarily behind, but you're missing the opportunity for that competitive advantage.
Right. I love that look just for, I mean, just blowing the picture out and looking at how we treat display measures more broadly and the importance of being really proactive in a program that measures very retrospectively. Yeah, it was a nice illustration. Well, anything else, Genia, you might have for us? I was wondering too, in the it's unique how you have your Medicaid population and your Medicare population. Do you have the same care teams working on both, or is there a handoff when members transition from Medicaid to Medicare? What
Yeah,
does
that's
that
a
look
great
like?
question. I mean, I think every plan may do it a little bit differently. For us here at Inland Empire, we have distinct teams that focus on the different product lines, and so a different team manages our Medicaid populations, and a Medicare DSNP focused care team is separate. So, but there's a lot of sharing and standardization, right? We're using the same tools, the same systems. And so I think there's a lot of cross functional learning that happens. And so the things we were doing for Medicaid earlier for this measure, just getting started, really did lay a nice foundation for us when we were thinking about what is this going to mean for us in the Medicare Stars world, right? So we did have a bit of a head start because we had some of that time already baked in with those care teams, and we have easy sort of plug and play solutions that could work on the Medicare side. So yeah, absolutely. You know, building off of what you do well within the organization in a similar measure or different populations can always be helpful as you're, gearing up for STARS performance.
Yeah, definitely. And for those of you who don't have the advantage of a Medicaid feeder to start experimenting in from the STARS perspective, and allowing for that slower plan, study, do, act process to play out, I would really lean into what Kori just spoke through us with. Do your background, do your research, do your work, learn what's happening nationally year to year. You can find all of that in the back end of every year's technical specifications that come out from CMS. There's a grid with all of that data right in there. It's easy to find. And to Kori's point too, you know who your national competitors are. A lot of that display data is publicly shared. Look up and see how folks are performing in your area and where the delta might be between what's happening nationally and what's happening locally and what's happening within your plan. I think is very directionally helpful in knowing where to start strategizing, right? Really a different focus if you're an outlier nationally and locally versus if it's a state issue when you have to get involved in state politics to remove the barriers in your way to change.
Yeah, and that actually brings something to mind for me, Jessica. I think just the looking at the network structure and the network makeup for your plan, right, is going to have a big factor here because how easy is your network to connect in, with as far as the EHR connections, that plays a huge role in your performance for this measure. So a plan like us here in Southern California, we have a very diverse network of providers. We are not connected to all of their EHRs, in a single system. So that can play a significant role. So when you're looking at how you're doing compared to those benchmarks, I love the different levels of segmentation, right? Look at how you're doing regionally with other plans. Also consider the network design and structure because I think that plays a huge role in your ability to perform in some of these much more sensitive to clinical data connection measures like this one.
Yeah.
Genia, you mentioned something when we were talking about this earlier around the instruments. So I think I was making an assumption that most providers are using a PHQ-2 or PHQ-9 in their standard assessments. And you made a good point that one of your bigger providers has a customized instrument that didn't quite meet that criteria. Can you talk a little bit more about that and how that's impacting your data outcomes, but also what you guys are doing to drive the positive change that you need?
Yeah, thanks, Kori. I think it's true. PHQ-9 and PHQ-2 tend to be the most common that we see across the network. We also see Promise as one that's baked into the Epic system, I believe. But we have some academic medical centers in our network that do really great work on social determinants of health, creating tools that do great kind of comprehensive screenings for their patient population. That includes depression screening, but it's slightly modified from the PHQ-9. And so because it's not that specific validated instrument that's recognized by the measure, we can't count that measure in the current state. And so we've been doing work in partnership with this large group to work with NCQA, work with the LOINC code entity to get that specific instrument recognized as a standardized tool. So I think that's an important, I think, component, that you dig deeper into as you start these conversations with your provider network about what is recognized by the measure, and asking, is anyone not using, these, and if there's a different tool that you are using, seek to understand that further so that you can figure out how to make that work in the measure itself. But yes, it was an assumption we all sort of made, and then we were surprised to find that there are other tools out there that are working really well in the clinical setting. They're just not recognized in the measure.
For you, I mean, what a perfect example, going back to looking at national, regional, local, your own, what a perfect example of not only recognizing like, okay, this is not a me issue, that this is kind of a regional issue, and what's causing it, this large provider, and then even taking the next step, how do I bring that forward to some of these regulatory entities? How do I bring that forward to NCQA? I mean, you're helping out your neighbors, but you're also helping out people, right? And getting them
Absolutely.
approved. And
I think they're meeting the intent of the measure, but there's a technical barrier, right, of getting that credit. And so working in partnership to figure out how to close that gap so that it does work.
that's right. Yeah, kudos.
We're not there yet. So, hopefully
Well,
we'll get over that finish line.
a lot further there than a lot of health plans that we speak with, for sure. Corey, anything else interesting you're hearing in way of that measure or tackling display measures generally from clients?
Really, I think it's really just taking the opportunity to understand current state, start testing early, and start getting that competitive advantage out front so that you can start out the gate really well.
100%. So, in the spirit of that, and all things we've chatted about today, if there are any of you out there who don't have this measure within your STARS work plan, as if it were a measure today, assigned to an accountable leader with documented interventions, outcomes, barriers, if you're not working that measure today, you saw the delta in Corey's display graph between those who start late and those who start early. You want to come out up here on that chart. I'd really encourage you to start to. That's a great. What do I do with this podcast information? That's a great go back today first step. Get it in your work plan. Get it ahead of folks. Display it as if it were a star measure, and start working out those kinks today.
Definitely.
Any departing words of wisdom, ladies?
Start the journey early. I totally agree with the advice, Jessica. Get started now. It's not too late. We're in the middle of the year, and I think there's still a lot of a good time to keep building those muscles that you need to do well in this measure.
Yeah,
That's
just
right.
remember, this is year 2 of display, and next year is the measurement year. So this is your time to test.
Absolutely.
Find out what works.
All right. Well, thank you all so much for joining us today. I hope to have you back soon, Genia. What a wonderful opportunity to hear about the work you and team are doing to serve Medicare and Medicaid populations out in California. And
Thanks for
Kori, as
having me.
always, thanks for sharing your analysis and all the insights you've gleaned from working with health plans every day.
Yeah,
So,
thanks for having us.
yeah. Take care, all.
Thank you.